Well, the high-frequency oscillator is a fabulous ventilator, but how you use it is what makes it a fabulous ventilator. If you don't use it properly, it's no longer a fabulous ventilator. Well, what is high-frequency ventilation? It's typically considered a means of ventilating patients using very small tidal volumes that are typically equal to or less than the dead space volume. And this slide sort of demonstrates where you are with IMV ventilation, jet ventilators, flow interrupters, and an oscillator can actually go to 20 hertz, although that is not a speed with which we would typically use it. With typically 15 hertz or 900 breaths per minute would be the maximum that we would use. If you look at this slide, this is how gas is exchanged. There are multiple ways in which high frequency works. Unlike conventional ventilation where you have laminar flow, high frequency operates best with turbulent flow, which creates a lot of mixing. You get a pendulum effect in the lower airways where gas exchanges from one side to the other, and you get better mixing from that standpoint. And when you get down to the alveolus or saccule, you really have moved diffusion back into some of the smaller airways, so you actually reduce the actual dead space volume of the lung. So with a conventional ventilation, ventilation is frequency times tidal volume, and that is how you get rid of carbon dioxide. So if you increase tidal volume or frequency by 10%, you'll increase CO2 removal by 10%. High frequency works very differently. It's frequency times tidal volume with frequency typically equal to about 1 and tidal volume equal to squared. Thus, if you alter tidal volume, it makes a much greater difference in carbon dioxide removal than altering frequency. So what are some of the critical factors that affect ventilation? Well, again, tidal volume, frequency, inspiratory time, bias flow, power on the device, and the resistance and compliance of the lung. All of those play a role. So altering any one of those will affect ventilation. And again, since it's tidal volume squared, small changes in tidal volume make much larger changes in carbon dioxide, either raising it or lowering it from that standpoint. And this slide sort of suggests that. Assume you have a frequency of 40 breaths per minute and a tidal volume of 8 cc's. VCO2 would be 320 milliliters per minute. If you have a 25% change in frequency or tidal volume, VCO2 increases to 400. However, if you're on a high-frequency ventilator at 600 breaths per minute with a tidal volume of 2 cc's, VCO2 would be 600 times 2 squared, or 2,400. A 25% increase in frequency would take you to 3,000, but a 25% increase in tidal volume would take you to 3,750. So you see the significant difference there. Tidal volume or amplitude, this is the key parameter for optimizing gas exchange using the high-frequency oscillator with that. Modulating the tidal volume during high-frequency ventilation is ventilator-specific. Amplitude, rate, inspiratory time can play a role, and flow. But many of that is dependent on compliance. So if you allow the lung to become less compliant by losing appropriate volume or over-distending the lung, you will then alter the ability to provide an appropriate tidal volume. And resistance in the lung is also a critical factor. So what is the role that resistance plays? Well, N is viscosity, L is length, R is radius. So a change from a 2.5 ET tube to a 3.5, the R factor is decreased over 4-fold. So altering the endotracheal tube can make a large difference, and allowing airways to slowly collapse will effectively do the same thing with those kind of patients. So how is tidal volume altered then? ET tube size, ET tube length, ET tube position, patency of the ET tube. So remember that as the ET tube builds up secretions in the inside, it's becoming smaller and resistance is going up dramatically. And so you're converting a 3.5 ET tube to a 3.0, and your tidal volume will fall under those circumstances. Lung compliance, airway resistance, chest wall compliance all play a role. The tubing we use is not very compliant, but if you happen to supplement with a somewhat compliant tubing, that will alter tidal volume delivered also. So let's summarize these factors affecting tidal volume. An increase in tidal volume is an increase in delta P, with the oscillator a decrease in frequency, a decrease in resistance, an increase or improvement in compliance. And remember, these are not independent, they're frequently additive. And remember, keeping the patient at an optimal mean airway pressure, meaning adequate lung inflation. Things that decrease tidal volume are a decrease in delta P, an increase in frequency, an increase in resistance, a decrease in compliance, and either having your lung at too high or too low a lung volume, so meaning too high or too low a mean airway pressure from that standpoint. Well, what are the critical factors in oxygenation? Well, getting the lung open to an appropriate mean lung volume, or MLV, improving pulmonary vascular resistance and getting rid of extra pulmonary shunts, improving cardiac output, hemoglobin content and function, and then obviously increasing inspired oxygen. Remembering that accomplishing that is typically increasing mean airway pressure from that standpoint. So if you have a lung volume that's too low, you get an increased shunt. If you have a lung volume that's too high, you have a problem with venous return and cardiac output and an increase in pulmonary vascular resistance. Remember that pulmonary vascular resistance increases as your lung goes to a low lung volume, improves as you inflate the lung, and then as you overinflate the lung, it increases again from that standpoint. So any of those things can then impair oxygen delivery from that standpoint. This slide demonstrates in an animal model we did that developed hyaline membrane disease what happens when you put the animal on high frequency instead of conventional positive pressure ventilation, and you're looking at a volume pressure curve. So you can see the slide with the, or the part with the triangles demonstrates that you have a much more compliant lung than you do with the circles that are the positive pressure. But notice as you go above optimal lung volume, you now at a very significant pressure change make a very small volume change. Again, you want the lung to be in the mid portion of that pressure volume curve. So what are some of the problems in maintaining an optimal lung volume? Well, changing compliance. One of the issues is once you get to an adequate mean airway pressure, your lung will inflate, but it will, as you improve compliance, it will continue to inflate. And so if you aren't aware of that and don't wean the mean airway pressure, you will wind up over-distending the lung from that standpoint. As the lung can possibly be injured, that can alter surfactant and surfactant production. And as surfactant is used up by the very small preterm infant, they may need a second dose of surfactant. Although in a study done out of Provo, they demonstrated that patients on high-frequency ventilation needed less extra doses of surfactant than those that were treated with conventional ventilation. And then, of course, there's effects on pulmonary blood flow. A change in systemic vascular resistance from overinflation and elevation in pulmonary vascular resistance secondary to low or high lung volumes, and then the risk of airway or alveolar rupture. Well, how is the pressure transmitted? Again, this is a study that we did when I was in San Antonio, in which we put a capsule on the surface of a rabbit lung, and as you can see with the high-frequency pulsation, which is the part on the left, has a very wide pressure swing at the top of the endotracheal tube. At the bottom of the endotracheal tube, it has become more sinusoidal, and it is markedly dampened. And when you get out to the alveolar surface, it is a very tiny pressure change, yet this animal is being appropriately ventilated. When you move to the right side under CV, you can see that what's happening is you get a fairly large volume delivered. At the end of the endotracheal tube, it's the same volume, and out into the distal lung, it's still a fairly large volume. So this is one of the ways in which high frequency is protective, because it reduces volume trauma in these patients. Well, how do you come about with appropriate initial settings? Well, I think you start with what's the pathophysiology of the lung disease being treated, what's the size of the patient, and settings will change as the lung disease changes and as the duration of ventilation is required. So what are the strategies for clinical management? Well, this is what this talk is all about. When you have diffuse alveolar disease in your preterm infant, we would use a mean airway pressure that's 1 to 2 higher than on the conventional ventilator. So if you're switching to a conventional ventilator, frequency is 10 to 15 hertz, because if you have just RDS, hyaline membrane disease, you can use very fast frequencies in the preterm infant, and a delta pressure that gives you some chest wall movement. And this is a baby with severe RDS. And again, how do you choose that? Well, if this baby was on a conventional ventilator with as white as this lung is and as poorly inflated as it is, one would argue that you probably needed a mean that's a little bit higher than 1 to 2 above. But once you initiate it, you gradually increase it until you see improvement in oxygenation. For the term and near-term infant, you're going to need a higher mean airway pressure than conventional, and I never use more than 10 hertz because many of these patients are infected and they have some predilection for air trapping from that standpoint. And again, you get a delta pressure that gives you a small vibration in the chest with that. And this is a baby with fairly severe lung disease. Now, I think one of the keys here is you will recognize that this baby's actually 9 ribs inflated. And some people would say, oh, well, that's where you want the mean airway pressure to be. But notice the lung is white. So whether you're at 9 or 9.5 ribs, you need more mean airway pressure to get this lung inflated. So it's not just how many ribs you're at, it's what does the basic lung disease look like that becomes very critical in the management of this patient. Some of these babies may need mean airway pressures of 30, 35, and in fact, this very baby that I treated in San Antonio needed a mean airway pressure of 40 to get the lung open. Now, we'll move on to another problem that can be treated effectively with the oscillator, which is the premature baby who has air leak. If it's interstitial emphysema as the air leak, we would use a mean airway pressure that's a little bit less than conventional as we're trying to allow the lung to deflate. We typically use faster frequencies because that reduces the leak of gas into the interstitium of the lung, and you want minimal chest wall movement. And this is a baby with fairly severe PIE. And in fact, this baby, I would tell you that you would probably want to consider using a somewhat slower frequency. The reason for that is there is so much interstitial air, it is compressing the airways, and it's giving the baby a predilection to air trap, and therefore using frequencies that are somewhat slower may be more beneficial for a baby who's this overdistended with PIE. Now, if you have gross air leak, again, the mean airway pressure would be equal to or maybe a little bit greater than conventional. Again, faster frequencies because that reduces leak through the hole that's in the lung from that standpoint, because it gives you, again, that very small peak to trough pressure from that. And if you look at this x-ray, you have a baby whose right lung is fairly normal in appearance, but clearly has a pneumothorax on the left. And again, you don't need a lot of mean airway pressure because the right lung is adequately inflated, but you do need a faster frequency and a small amplitude for that kind of a patient. For the term or near-term infant, one of the keys is, well, what do you do with a patient who's poorly inflated? Well, this patient is going to need more mean airway pressure without question because you've got to get the lung to inflate. Again, 10 hertz would be the maximum frequency used because remembering that babies who are term or near term and have air leak often have pneumonia and have some predilection for air trapping. So many of these babies, one might look at using even a bit slower frequency like 8 hertz. And this is a good example. On the right side of the chest, you have a pneumomediastinum. You have a very small right pneumothorax. On the left side, you have a chest tube and a left pneumothorax. But the overall inflation of the lung is very poor. And therefore, you are going to need more mean airway pressure to get this lung inflated. But once it inflates, you need to make sure that you back off on that mean airway pressure. Now, on the other hand, if you have adequate inflation, then you don't need to increase your mean airway pressure. And again, using frequencies of 8 to 10 hertz would make sense. And here's a perfect example. This baby's had quite a bit of air leak, has 3 chest tubes in, but on the high frequency ventilator, because the overall inflation of the lung is adequate, you don't need to increase the mean, and using a somewhat lower mean with very small peak to trough pressures means you will clear that air leak fairly rapidly. Now, what about non-homogeneous lung disease? This probably taught me more about the oscillator than anything, because when I first tried it on these kind of patients, I was using 10 hertz because that's what we used in the animal, that's what we used in a lot of our babies when we first used it. And I once said that it wasn't very good for meconium aspiration with air trapping. But one day, while I was waiting for one of my friends to put together an ECMO circuit, I thought to myself, well, you know, this fast frequency may be air trapping this patient. I turned the frequency down and the patient got dramatically better. So again, the key with meconium aspiration is an adequate mean airway pressure, but a decreased frequency, typically in the 6 to 8 range, and more likely in the 6 to 7 range. And you should have good chest wall movement, which helps mobilize that. And here's a perfect example of a baby that's severe meconium aspiration, has multiple chest tubes, but this type of patient can be managed appropriately with the oscillator with appropriate settings. But every once in a while you get a baby who somebody maybe suction a little meconium out of the trachea, but when you look at the x-ray, it doesn't look like meconium aspiration. It's really diffusely hazy. So it's more of a surfactant deficiency problem. And again, these patients are going to need more mean airway pressure to get the lung open, but they still need the lower frequency because if they have meconium in the airway, that will predispose them to air trapping and create problems for the baby. And this is a baby who, again, doesn't really look like meconium aspiration, but had some meconium suction from the airway. So this baby gets treated more like a baby who has an RDS, hilum membrane type picture, because it's more of a surfactant inactivation issue with that. Well, what about focal pneumonia? We do treat particularly babies with group E strep disease. Again, a mean airway pressure that's equal to or maybe even a little less than the conventional ventilator. Again, a lower frequency because this baby has a predilection to air trap. And here you have a baby who has bilateral lower lobe lung disease. This baby actually had group E strep infection, but the upper lobes are normal, so pushing this baby's mean airway pressure would not be beneficial because you would overdistend. Remember that babies with group E strep disease often have pulmonary hypertension, and you want to avoid overdistending the lung because of that. Well, the next one is pulmonary hypoplasia, which comes in several forms. One form we would call uniform, which means that both sides are pretty equivalent with that. Again, you would start with a mean airway pressure that's equal to your conventional ventilator. You would advance 1 centimeter of water until you see an improvement in oxygenation. Frequency should be faster for these babies to minimize peak to trough pressures in the distal lung and hopefully minimize injury to what is now a small lung. This baby is a typical baby who would have that, who has severe high drops at birth and has very small lungs. This baby, on the other hand, is a small preterm infant whose mother ruptured her membranes at 16 weeks. This baby was delivered, a baby I took care of when I was in Pittsburgh, delivered at 26 weeks gestation. Now, what I am telling you is critical. Notice this chest. 1, 2, 3, 4, 5, 6, 7, 8 ribs inflated. And so if somebody says, oh, well, you need to be 9 ribs inflated or 9.5 ribs inflated to have adequate lung volume, you will create a pneumothorax in this baby because notice the lung fields are relatively clear. And in fact, this baby was on a mean airway pressure of 25 at this time. But that's all the baby needed because you want the lung to be clear. So again, what does the lung look like? Not necessarily how many ribs are you counting with what's going on in the lung field. Well, what about non-uniform? Again, mean airway pressure equal to or a little bit greater than the conventional ventilator, but it's really dependent upon the normal lung. Frequency 8 to 10 hertz in these patients. And again, this is the child who has a diaphragmatic hernia. So it's got one very small lung. This is a left-sided hernia, so a very small lung on the left, has a much more normal lung on the right. But one of the keys is making sure that that lung is adequately inflated. This lung, I would argue, is a little bit more inflated than it needs to be, but you should always see some space below the heart border. And if you count ribs, you're probably going to get to 10 or 10.5 ribs in this baby. So again, sometimes you need 10.5 ribs, sometimes you need 7.5, 8 ribs. Depends on the baby, and it depends on the lung from that standpoint. Well, how do you adjust high-frequency strategies as pathophysiology changes? I think that becomes an equally important issue with what we're looking at and doing with it. All right, so you have diffuse alveolar disease in the preterm. So if the strategy is not working, what should you be thinking about? Or if this patient requires assisted ventilation for more than 1 week? Well, one of the things you want to know is, what does the mean airway pressure do? Well, what's its effect on airways? Its effect on airways is to open them up and hold them open. Its effect on lung volumes is to improve lung volumes. Its main effect is on oxygenation. But if you've allowed airways to collapse from that standpoint, you will have an alteration in carbon dioxide also, and if you overdistend the lung, you'll have an effect on that. So while the mean airway pressure's predominant effect is on oxygen, it can have an effect on carbon dioxide. So what's wrong with this patient? Well, this patient was left on 15 hertz because that's what worked early on. But as the lung disease changed, this patient has gotten into more trouble, and no one bothered to wean the mean airway pressure on this baby. And this baby got very overinflated, and as you can see, wound up with a pneumothorax. So as I try to tell people, if all else fails, try examining the patient. So when this patient was optimally inflated, the liver was probably down about 1 centimeter. When this baby wasn't doing as well, if you examined the baby, you would have found the liver down about 3 centimeters, and you would have already known that this baby is overdistended, and you should have been weaning the mean airway pressure on this baby. Well, what about frequency? Frequency's effect on the airways is minimal because it's peak to trough issues, but the faster the frequency, the smaller the peak to trough, so you really aren't opening airways very effectively. Its effect on lung volume is if you're too fast, you'll tend to overdistend the lung by air trapping, and then you will have an adverse effect on oxygen and carbon dioxide. And here we have a baby who again has developing chronic lung disease. The problem with this baby is you look at the baby and say, oh, baby's overinflated, wean the mean airway pressure. But that's not the issue with this baby. This baby is on too fast a frequency because as the airways develop problems with chronic lung disease, you get an airway issue and fast frequencies tend to air trap. So part of weaning a baby who's been on a ventilator more than a week is reducing the frequency, but also reducing the tidal volume at the same time because you won't need as much tidal volume because the lung will no longer be overdistended. And with this, well, let's see, where are we here? So, and if you develop atelectasis, then amplitude becomes a very important part in opening up that area of atelectasis. As we all also know, repositioning the baby with the good side down may also help you improve that from that standpoint. So from a term standpoint, it's almost always mean airway pressure, meaning that someone has not provided an adequate mean pressure for this patient. And you can either have an inadequate mean or you can have too much mean. And either of those become important, but in general, it's too little mean. This patient has a more than adequate mean airway pressure, as you can see by this baby being 9.5 ribs and very clear looking lung fields. This baby, on the other hand, has about the same volume, meaning rib counting, but look how much lung disease there is. And so someone says, well, I think I've inflated the baby. The baby's at 9.5 ribs, but the lungs aren't inflated. And again, you have to go by lung inflation. That becomes a critical part of what you're doing from that standpoint. From a frequency standpoint, again, you have a baby who has some pneumonic process, and somebody's decided, well, we use 15 hertz for everybody. So they put the baby on 15 hertz, and the baby winds up air trapping, and they wonder, why is the baby air trapping? They turn the mean airway pressure down. It doesn't help. The baby remains air trapped. They say, get rid of the damn ventilator and put the baby on another one. Well, the answer is, it's not the ventilator's fault. It's the driver of the ventilator's fault, because you are air trapping this baby by being on too fast a frequency. Remember, term infants never more than 10 hertz, and typically 8 hertz would be a better number for them. From an amplitude standpoint, again, remember, amplitude opens up airways, increases lung volume somewhat. And again, you have a baby who has an atelectatic left lung. Going up on amplitude will help you open this lung from that standpoint. But remember, you don't want to be on real fast frequency, because this is probably in part due to secretions, and therefore a slower frequency and a bigger amplitude will open up that atelectatic area. What about from non-homogeneous lung disease? So we're talking about the baby with meconium aspiration. Again, virtually every time this baby is not doing well with an oscillator, it's because someone is using a frequency that is excessive. And I can't tell you how many times I get a phone call from somebody, so they've got a bad meconium aspiration, the damn thing won't work. What's wrong? And the first question I ask, what's the frequency? And it's 10, 12, and sometimes 15 hertz. All of those are absolutely contraindicated in the meconium aspiration. You want the 5, 6, 7, 8 hertz maximum in those patients, and you will get a much better outcome from them. So again, appropriate mean airway pressure to keep the lung open and get your patient where you want to be. Again, this is the baby with pneumonia. It's got non-homogeneous lung disease. You want an adequate mean, but you don't want to overdistend the normal lung, because you may increase the risk of pulmonary hypertension in a patient who already has pulmonary hypertension. And this baby, again, has an inadequate mean airway pressure. He's got a pneumonia, and you don't have an adequate mean airway pressure in this patient because you have a lot of infiltrates and you have areas that need to get adequately inflated. And then this baby is way overinflated because this baby has, unfortunately, been placed on too high a mean airway pressure from that standpoint. Well, now what we're going to do is go through a couple case studies so that you can get an understanding of what's going on and what you should be doing with the patient. So this is a 2 kilo, 33-week female who had a prenatally diagnosed left diaphragmatic hernia. The patient was stabilized, and this is the chest film on a high-frequency ventilator with stabilization. Notice what I was talking about before. You can see the lower heart border. There's a little bit of lung below it. You can actually see a little bit of lung on the left side that has inflated, that hypoplastic lung. You can see lung in the upper part. So this baby is perfectly inflated for a diaphragmatic hernia. Count the ribs, and you'll find the baby's probably 10, 10.5 ribs inflated. So the baby's on a mean airway pressure of 14, a Hertz of 8, an amplitude of 32, 100% oxygen with a PO2 of 124, and a CO2 of 42. So somebody looked at that x-ray and said, whoa, this baby's too inflated. That right lung is more than 9, 9.5 ribs, so they turned the mean airway pressure down. And noticed that the baby wasn't quite as good, but really didn't get very sick at that moment in time. But when you look at the x-ray, look what happened. The left lung that was inflated has now lost its inflation. The upper lobe isn't quite as well inflated, and you have some air along that lower heart border, but it's not completely underneath of it. So this baby is losing lung volume. And the problem is the baby will continue to lose lung volume, but somebody decided, well, the kid's still almost 10 ribs inflated. We'll get down to the mean of 12.5. Everything else is left the same. The baby had been weaned down in oxygen a little bit. But an hour later, on the same settings, the PO2 is now 68, and the CO2 has remained 43. And you look at the x-ray now, and the baby's even a little less inflated than previously. So they recognize that this baby's gotten worse, so they increased the mean to 13. That didn't help. They went to 13.5. That didn't help. They went to 14. I arrived on the scene, and I said, well, you know, once you allow the lung to de-recruit, you're going to have to go above the mean to re-recruit the lung. So this lung was a little better, but not much better. So, and the baby was still on 100% oxygen with a PO2 of 51 and a CO2 of 46. And so we increased the mean to 15.5. And notice, we managed to get the lung back to where it was previously. So you have good inflation in the right, and you've got some inflation in that small left lung. Over the next 12 hours, we were able to wean the FiO2 down. And after that, we were actually able to wean the mean airway pressure down a little bit also, but we did not go below 14 because we recognized that when you went below 14, that created a problem for the patient. Okay, so our next case study here is a 26-week male, day of life 14. His vent settings are mean air pressure 10.5, frequency 10 hertz, amplitude 14, FiO2 35%. Blood gas 732, PO2 62, CO2 48. And this is his x-ray. So I think we all would agree that this baby looks a bit overinflated. The diaphragms are relatively flat. And if you count ribs, this baby is a little bit overinflated under these circumstances. So based on this, someone said, well, we need to wean the mean airway pressure. So they went down to 9.5. They left the frequency alone, amplitude 18. Now the baby's in 50% oxygen. And the baby remains on those settings, and now the CO2 is rising. Follow-up x-ray shows still somewhat overinflated. Now we've started to develop atelectasis in the lung with that by going down on the mean airway pressure. So I think you need to compare the following chest film. This chest film is clearly an overinflated chest film due to a too high mean airway pressure. How do we know that? Because the lung fields are clear and the diaphragms are flat. Notice this one. This is an overinflated lung, but the lung fields are not clear. And so one of the problems is that you are air trapping this baby from too fast a frequency. And as I mentioned before, once you get into chronic lung disease, you need to start going down on the frequency. And if you do that, you will not overinflate this lung, and you'll be able to continue to wean the oxygen level. So what about extubation? Well, you can and should extubate babies directly from the high-frequency ventilator. If you weigh more than 2 kilos, a mean airway pressure of 11 to 13, amplitude of 15 to 22, frequency 6 to 10 hertz, and they will be extubatable to CPAP or NIPV, and some of them even to a high-flow cannula. 1 to 2 kilo babies, a mean a little bit lower, 9 to 11, amplitude 12 to 20, frequency 6 to 10 hertz. Frequency doesn't seem to matter much. And again, for the smaller babies, CPAP would be a better extubation. The bigger could probably go to a high-flow cannula or either of those to a NIPV. You're less than a kilo, mean airway pressure 6 to 10, amplitude 10 to 16. Most of these babies are on faster frequencies, 7 to 12 hertz. And again, the small babies should be on caffeine before they are ever extubated, and that would help you from that standpoint. And these babies should all be extubated to CPAP or NIPV, CPAP with a rate. So, in summary, what is mean airway pressure? Its main effect is on oxygenation. It assists in keeping the lung at optimal lung volume. Too low or too high affects PaCO2 and also adversely affects PaO2. So remember that. PaO2 is achieved best by an appropriate mean airway pressure where typically the lung is inflated to 9 and 9.5 ribs. But remember, can't stress this enough, the best marker is our lung fields clear. And this might require an 8-rib inflation or a 10-rib inflation. So that's what you're really looking for. Amplitude. Main effect on ventilation will open up atelectatic areas and improve oxygenation. A key is, if your amplitude is 3 times your mean airway pressure or greater, you need to reassess your mean pressure and your frequency, because you're making it more like a conventional ventilator by using amplitude to reopen lung that's allowed to collapse, and this is likely to not be lung protective. Frequency, well, as I've said time and time again, if I only wanted a single frequency, I wouldn't have put a damn frequency knob on the ventilator. Using only one frequency defeats the usefulness of this device, and if that's the way you're going to use it, you probably shouldn't use the device. Certainly not for a lot of the lung diseases we use it for. Slower frequencies should be used for air trapping issues and for non-homogeneous lung disease. And remember, persistent pulmonary hypertension is frequently a part of patients with severe pulmonary dysfunction. In these patients, if the lung is adequately inflated, increasing the mean airway pressure because they're not oxygenating will harm the patient, not help them. And with that, I will close, and I am happy to answer any questions that you all may have. Thank you very much for your time.
Thanks, Dr. Null. That was a really good presentation, especially like your commentary regarding frequency. So right now is a great time. If any of you out there are listening, we have a great resource here. We have about 10 minutes before our time is up. But if you have any questions, please feel free to type them in the bottom box that says questions. Our first question is pretty topical. Right now, Dr. Null, there's a bunch of discussion going on the AARC email list that talks about suctioning on high frequency. These questions come up. It's probably one of the more common questions I get as product manager is, do we suction with the frequency on, or do you pause the ventilator and suction with the frequency turned off?
Well, I think that's always a good question. My answer is that if you have patients who are in a state of somewhat overinflation because of air trapping, then you are better off suctioning by pausing the ventilator. If you have a patient who has a somewhat lower lung volume, then you're actually better off leaving the ventilator on when you suction the patient from that standpoint. But one of the keys is to remember that suctioning can de-recruit the patient. If the saturation, let's say the saturation has been running 92, 94, you suction the baby and the sat is now 88. If over the next 10 or 15 seconds it starts to come back up, you don't have to worry about it. If it doesn't, then the goal would be to turn the mean airway pressure up by 1 to 2. And as soon as the oxygen, or as soon as the sat gets back to where it was, go back down on the mean airway pressure. And that allows you to avoid turning the patient into 100% oxygen and providing an oxidative stress that's not particularly beneficial to the baby.
Cool. All right. Now, with regard to patients with air leak or air leak syndromes, besides ventilator changes, how important is it to position the infant? You know, prone, supine, bad lung down, that type of thing.
Well, I think it is helpful, particularly with PIE, that you should put the, if the baby has more severe PIE on one side than the other, that should be the side that goes down. The same with a significant air leak. If you put that side down, you can deliver a little less volume to that side, and you can allow that leak to heal. Remember, the reason babies get such severe PIE is because their leak is not at the saccule. Their leak is in one of the distal airways. And so what you're trying to do is minimize the peak to trough pressure in that area, which is allowing gas to escape. By putting that side down can be very beneficial for them.
You talked about changing frequencies. What about IE ratio?
Yeah, I think that's a good question. We have always used an IE ratio of basically a I time of 33%. The reason was some of the early studies that were done with high-frequency ventilators that had a 1-to-1 IE ratio, one of their problems was air trapping with patients. And we recognized that if you could alter, and that was one of the positive things about the 3100 ventilator, was you could alter inspiratory time. And so we recognized that if you used a little bit less inspiratory time or duration of duty cycle on inspiration, you could more effectively avoid air trapping in those patients. But there are times when you need to deliver a little bigger tidal volume, and that's accomplished by increasing the inspiratory time. And there's some evidence in some of the severe meconium patients, you can remove some of the meconium better by having a little bit longer inspiratory time. but again becomes very critical using lower frequencies, or you will get into problems with air trapping.
Okay, you know what? We have a hospital here that says they ventilate really small babies, usually less than 800 grams. They're usually 24, 29 weekers. Should they use higher frequencies, 12 to 15 hertz for the first week?
The answer is I have found 10 hertz to be a very ideal frequency. The reason is that, as I'm sure they know, a portion of their babies are going to be infected, and if you're using 12 to 15 hertz, you are likely to air trap them even before they get into a more chronic stage. So I typically start 10 hertz, but if my amplitude becomes very small and essentially approaches the mean airway pressure, then I would consider going up on the frequency, which of course would reduce the tidal volume as a means of not over-ventilating the patient. But personally, I like to start on 10 hertz and then sort the baby out. So if they have clearly no infection, then many of them can be managed very effectively on 12 hertz.
You just briefly mentioned tidal volume. How do you gauge tidal volume on high frequency?
I gauge it by looking at the chest wall movement. I think for small babies, you want to see a small chest wiggle. And for like the meconium aspiration, you need to see the chest wall bounce better. So I think that's how I look at it. And then, of course, I use a blood gas to assist me in adjusting and fine-tuning it at that point. But when I set up, I start them on a mean that I think would be adequate. So if I'm intubating a brand new small preterm infant, we'll say it's a 25 weeker who weighs 800 grams, I would start with a mean airway pressure of 10, and I would adjust upwards as needed to improve oxygenation, and I turn my amplitude up to see a chest wiggle, which will be typically somewhere between about twice what the mean airway pressure is. Typically, I would never go above twice. So for me, it would be an amplitude of typically 17 to 20 with a mean airway pressure of 10. And I look at the chest, and if I've got a reasonable wiggle at that, I wait until I get a blood gas.
Okay. We got quite a few questions in just a short amount of time, so now it's going to be rapid-fire question time. Okay. You didn't mention flows. What are your thoughts on setting flows on the 3100?
Well, the flow should be set so the device that keeps the mean airway pressure where you want it is between 10 o'clock and 2 o'clock.
Okay.
So that's where you want that set, and that's how you set your flow.
Okay. So basically, you want your limit knob somewhere near the top to kind of give you a broader range of turning it.
Correct.
What about sedation and chest X-rays? How often do you do chest X-rays, and what kind of sedation?
We will sedate babies who need it, and we will use something like Ativan and either fentanyl or morphine for the babies. I don't like to over-sedate them. I typically start all of the babies on caffeine because I think having them support breathing is important and assist you in getting off the ventilator faster from that standpoint. And I don't like the patients over-sedated.
Okay, Dr. Null, I appreciate taking your time. We're right at the 1 hour mark. We have a few questions left, And for those of you that didn't get an answer, we will make sure that we will have these answered by Dr. Null and get them out in the next week or so. With that, for those of you that are getting continuing education units, please stay on, take a look at the survey and fill it out so you can get credit. Please remember that this webinar will be available in a couple days, so if you missed anything, feel free to come back. Questions are answered, we'll make sure that those questions are placed on the webinar page as well, so the people taking the webcast later will have the full benefit of everybody's questions. With that, thank you very much, Dr. Null. I appreciate you taking your time out of your busy day to do this. And everybody else, thank you very much for coming in, listening to this very timely webinar, and I look forward to hearing from all of you. Take care and have a great day.
All right, you're welcome.